Hi everybody, welcome to this new video. Today I'm going to talk about pulmonary embolism. I had to give this talk on emergency medicine course that was given here in Chile. That's called Conceptos 2015. It's organized by PEAC, Universidad Católica. It was a great course, very well organized, very high tech, and great speakers. I mean, I had a great time, so thank you, Cristobal and to Pablo, for inviting me to this convention. Second, I wanted to thank Jim Horowitz from the PEAC team at Cornell University, because he was kind enough to review this lecture with me before I gave it. So thank you very much for that. Thank you for your time. My talk was about PE and the critical patient with PE. So I didn't have enough time to talk about everything about the patient that's critically ill with a PE. So I decided just to focus on the lytics, okay? Who needs thrombolytics on PE? Because here in Chile, it's not very well known, the indication, and people are not using thrombolytics for PE. So I thought it was interesting to talk to them about this and for them to know who needs this medication and who doesn't. So this is a 75-year-old lady that arrived during my shift to my hospital. She was previously very well. She was cooking breakfast for her family, and suddenly she had a syncope. Her daughter heard her, so she picked her up, and they called EMS, and they brought her to the hospital. In the ambulance, she started with chest pain and with difficulty breathing. So it's a syncope with chest pain and difficulty breathing. When she arrived, it was obvious she wasn't looking good. She was really sick. Okay, she was tachycardic, she was hypotensive, she was tachypneic. So it was very obvious to me that she wasn't good. She needed me to diagnose her quickly and treat her. No matter the things we had to do, we finally got an ultrasound machine, and a very old ultrasound machine, so we were able to do an apical 4-chamber, and we found this. We have a very large right ventricle with a decent left ventricle function. Okay, so the diagnosis at that point was very obvious. Okay, it's pulmonary embolism. So we were very happy. We would high-five each other. We hugged each other. But then I remembered that my patient wasn't doing that great. Okay, she was really sick. So now that we had the diagnosis, we need to treat her. And we started with high flow O2 with a couple of IVs. We started heparin. I think that if you have the clinical suspicion plus your ultrasound, you have to start heparin. But the problem with heparin is that prevents the clot from growing, but it doesn't do anything to the clot itself. That's already there. So we're going to talk about that. Well, we thought to start fluids, but I just want to spend a couple of seconds here telling you why it isn't a good idea to start fluids in this particular patient. Okay, the problem with PE is that we have a right ventricle outflow obstruction. Okay, that's a clot, and when that happens, the RV increases its volume. Okay, it's dilated, and this takes us to a couple of situations that are very bad for the patient. First, the RV dilation produces a septum shift to the left. Okay, and second, as the right ventricle is used to function with lower pressures, now that it's huge, there's important pericardial restriction, so it can't grow anymore. The septum shift takes us to decreased left ventricular filling, and the pericardial restriction causes our preload to go down. And both of these things explain the decreased left ventricle volume and the shock state that the patient is showing. So we're not making her any favors if we start giving her fluids and just getting this worse. Remember that the outflow obstruction, it's still there. So if I give her a lot of volume, a lot of fluids, it's just gonna make that right ventricle bigger, more pericardial restriction, more septum deviation, and more shock. So beware with the fluids, because these patients don't need fluids. Even they can make it worse. Okay. So what else can we do for this patient? And doing some research for this, I found the pulmonary embolism acute care team from Cornell Medical College, Cornell University. This is Dr. Friedman and Dr. Horowitz that I already mentioned to you, that he was kind enough to review this with me. And they have a pager that every time a PE comes into their ED or the people that are admitted, it's a multidisciplinary team. They have intensive bronchopulmonary intensive care, cardiology, interventional radiology, and cardiothoracic surgeon. And so they get together, they analyze the case, and they decide what treatment is best for that patient. Our reality, it's a little bit different. This is the distance that if I call for any help at my hospital, they have to run, okay? Because our ED, it's separated from the rest of the hospital. So we don't have any like multidisciplinary team. We're basically butt naked if we need help. So that's the context in which this lecture was given. But the funny thing is that one of the things that we have, it's TPA, okay? And you would wonder why you have TPA. Because my government decided that it was a good idea to have it for ischemic stroke. I'm not gonna even start talking about that, but I think that the only good news about having TPA for stroke is that we can use it for people with PE, okay? And that's it. There's no other reason to use it. And so in which patient should we break the rules and take the stroke TPA and use it in another patient? And if you analyze PE, you know that it's a clinical spectrum, okay, that goes from people that are asymptomatic, people that just have a little chest pain, a little dyspnea, but you see them and they're not tachycardic, they're not tachypneic, they're just complaining of shortness of breath or chest pain. Then you have people that had a little bit of hemoptysis. Now you look at your patient and he's tachycardic and he's tachypneic, okay? Beware with those patients because there's something wrong with them. Then we have the syncope that for some reason there was a very acute right ventricle increased volume dilation, enough for the patient to do a syncope, okay? And then they're back and now they're sitting in front of you. Then you have the patients that are clearly in shock, like the patient I told you, and finally you have the patients that arrives in cardiac arrest. We're going to focus on this population, and even more we're going to take out the people with PE and cardiac arrest, okay, because that's another different topic. Either you believe in lytics in the context of cardiac arrest or you don't, but we're going to focus on this population. We always have been taught that PE can be massive or submassive, okay? And that sounds about right, but when you start reading literature, you find very confusing nomenclature, okay? You have submassive with RV overload, submassive with ischemia, submassive without ischemia, radiologically massive, so high risk submassive, and it can be very confusing. So the first thing I want to tell you is that I think it's worth to make the difference, because if you see this graphic, this is from paper of Wood and Test 2002, when a patient with PE arrives in shock, his mortality is around 30%. But between the 0 and the 30, there's again a spectrum of patients. And how do we know where the patient I have in front of me is, if he's not evidently in shock? And the invitation they do is you have to try to risk stratify by the right ventricle dysfunction, meaning that if my patient has evidence of right ventricle dysfunction, he probably is going to be closer to the 30% mortality than closer to the 1%, okay? Put it in another way. This is from Jim Horowitz. Low risk PE has less than 1% mortality. Submassive goes to 3 to 9%. Okay, there's a huge difference there. And massive from 25 to 65. So we need to focus on the submassive population because low risk is easy, massive it's easy to recognize. So with submassive we might have a little problems. If you look the AHA guidelines, the definition of massive PE is basically a PE that's hypotensive, okay, for more than 50 minutes, that requires vasoactive drugs, that's bradycardic less than 40 or pulseless, okay, that's basically a massive PE. When you look submassive, it's without hypotension, systolics over 90 milligrams of mercury, but with evidence of right ventricle overload or myocardial ischemia. When you look the low risk, it doesn't have a hypertension, it doesn't have a right ventricle overload or ischemia. And we're going to, as we said, we're going to focus on this group, okay? Because here the mortality varies a lot, goes to 3 to 10%, okay? And that's a huge difference. How do we recognize where my patient is? And as I told you, we're looking for two things in this population, okay? The PE that is not hypotensive, but has evidence of right ventricular dysfunction or myocardial ischemia. So according to AHA, these are the criteria for submassive PE. Getting a dilated right ventricle in the ultrasound or in the CT, finding right ventricular systolic dysfunction on a formal echocardiogram, have a BNP or a pro-BNP elevated, having EKG changes showing right ventricle dysfunction, or having elevated troponins. The problem with this criteria is it isn't clinical. Okay, it just shows you by imaging or by lab values that there could be a right ventricular dysfunction, but it's not clinical. So some of these patients, the only criteria they met is that they have elevated troponins, but clinically they look great. So it's the same as the patient that's not hypotensive, but is, I don't know, tachycardic of 140. It can be the same, okay? And when you try to put the clinic in, you have this, the pulmonary embolism severity index, that for me it's like this San Francisco syncope rule, okay? If you've been around for a while, you are a trained emergency physician, doctor, you've been working for, I don't know, 5, 6, 10 years, you're not going to use this score. Okay, because it's already incorporated in your clinical gestalt. If you're a resident, could be useful. If you have been around for a while, trust your criteria, and it has been more useful in trying to identify the low-risk patients, the ones that doesn't have any of these criteria and that you're thinking of sending home. We're talking about a different population here, so don't rely on pulmonary embolism severity index. What do our PEAC team friends tell us? Well, they tell us that regarding to treatment, we need to separate people with PE in these two groups, okay? Low risk or stable submassive versus high risk submassive and massive. Because the first group, you're not going to give them lytics, and the second group, you should give them lytics. This is a meta-analysis published in JAMA 2014, and I took this from the bottom line site, and if you take the submassive PE and massive PE people, you can see a mortality benefit, okay? And nowadays it's harder and harder to find interventions that have mortality benefit, and this it has an OR of 0.5 and a number needed to treat of 59. So I need to treat 59 submassive or massive PEs in general to save one. And when you see the primary adverse outcome, that's major bleeding, of course I'm given a thrombolytic, so I expect people to bleed more. And the odds ratio is 2.73, and the number needed to harm, it's 18. Okay, so for every 60 PEs that I give lytics, again, in this very broad group, okay, submassive and massive, everyone is invited. For every 60 I give lytics, I avoid 1 death, but 3 are going to have a major bleeding. Okay, that's when you took all patients. When you do a little subgroup analysis, I think the most important is the analysis on age. Because if you have a PE and patient has less than 65 years old, the number needed to harm goes up to 175, okay? and the mortality benefits, it's the same. So I have a number needed to treat of 60, but if patient is less than 65 years old, I have a number needed to harm of 175. Okay, so that's a very good risk benefit equilibrium. The thing is that the problem with these studies is that they didn't really separated the stable submassive versus the high risk submassive. They put them all together. And when you take only the stable submassive, there's still a bit of a benefit mortality, but it's less than when you take them all. And the bleeding, it's more or less the same. Okay, so for me the important thing about this meta-analysis is that first it shows that it has a benefit mortality, and second it shows a subgroup of patients that are even more benefited by this because their adverse outcomes are less frequent, and that would be the patients that have less than 65 years old. So we have the two ends of the spectrums. We have the low risk that clearly don't need thrombolytics. We have the other end of the spectrum, that's the patient in shock and evident shock, and they clearly need thrombolytics. And we have all this population in between that we have been calling them submassive PEs. And what we need to do with them is do a good risk-benefit assessment and try to decide which of these patients that are in between are going to benefit from thrombolytics. The thing that we need to do, and the challenge, is we need to try and separate this whole clinical spectrum between these two groups, low risk and stable submassive versus high risk submassive and massive. Because the first group, the low risk and the stable submassive, clearly don't benefit from thrombolytics, and the high risk submassive and massive clearly benefit from thrombolytics. How do we do this? We have a lot of ways to do it. We have EKG, we have ultrasound, we have troponins, we have BMP, we have a lot of stuff in order to look for right ventricular dysfunction or myocardial ischemia. But I think that clearly the most important is the clinical aspect of the patient. Okay, you need to get good at it. And one of the great things about the PEAC team is that you're concentrating lots of PE, so they're getting very good at it. Because they're seeing lots of patients with PE, and that clearly gives them advantage over other physicians or over other specialties. They're taking care of many patients with PE, so they're getting very good at it. You need to practice, you need to do shifts, you need to take care of patients in order to get good at this. Get your gestalt better. Don't trust on scores and stuff like that, because it's going to prevent you to, or it's going to lower your opportunity of making yourself a good gestalt. Just remember that the answer of emergency medicine is always at the bedside. The patient has all the clues and the keys that we need. So what do we did with our patient? This is the picture I show you when she came in. Take a look at the hour on the right upper corner. It's 10:16. We decided, for me, the patient was clearly in shock. Okay, this is the guy that had the TPA. I had to talk with him because the first answer from my nurse was, okay, you can use the TPA because that's only for strokes. So, and it has to be approved by a neurologist. And totally like, come on, why should I talk with a neurologist about a patient that's having a PE? And for worse, at that particular shift, there was no neurology in the shift. So I couldn't talk with anyone, and the first couple of answers were, no, you can't do it, you can't do it. So I took this guy and explained him, what do I need it and why did I need it? And he understood perfectly, so he gave me the medication. We used 100 milligrams in 2 hours, the first 20 milligrams in 20 minutes, and then the rest in the hour 40 minutes. And take a look at the time, it's 10:50 now, 45 minutes after we started with the lytics. And we were able, she's a little bit more tachycardic, but we were able to suspend norepinephrine that we were giving, and look at the pressure. Okay, she's not 101/69. She's still struggling with the tachypnea and tachycardia, but she was clearly better. You could see her, and now perfusion was better. She looked a lot better. Okay, so clearly that make a difference. And 48 hours after that, they managed to get a CT of her chest that showed the bilateral PE. It's very distal, but remember that this was taken 48 hours after she presented at the hospital. If we could have taken the CT when she arrived at, probably it would have showed a bigger clot and more proximal, because it's difficult that a PE this size that I'm showing you causes a shock state. I mean, it's not impossible, especially with a patient with a very diminished cardiovascular reserve, but this wasn't the case. This old lady, she was 75, but she was doing great, and she had a normal cardiovascular basal situation. So if I think we're seeing what was left of the clot after the thrombolytics. Fortunately, patient did great. She was discharged a couple of weeks later, and fortunately, she did great. She's happy at her home now. So what's the bottom line here? First, I think that a good clinical evaluation of pulmonary embolism is vital. You need to get good at it. You need to see a lot of PE patients in order to convince yourself that they're going to benefit from lytics. The right ventricular overload is what we're looking for in order to see if the patient benefits from lytics or myocardial ischemia. Massive PE should be synonym of equals to thrombolytics. Okay, they benefit a lot. And submassive PE, we need to get a very good risk and benefit assessment or evaluation. We need to pick the patient that's going to benefit more from lytics. And as I told them during the lecture, the more information you need to convince yourself the patient is going to benefit from lytics, it's less likely the patient is going to benefit from lytics. Okay, it should be clinically evident, clinically obvious. If you need a pro BMP and that's the only thing that you have to call that patient a submassive PE, probably he's not going to benefit from lytics, and you're going to give him all the risks. That's major bleeding, smaller bleedings, etc. So try to get good at the clinical evaluation of these patients in order to decide which patient is going to benefit from lytics. Okay, it was my pleasure. Thanks again to Jim Horowitz from the PEAC team. Thanks again to the Conceptos organization team. It was a very good course, and I was very happy to be there, and hopefully I'm going to be there for next year's. Okay. Follow us in Twitter, follow us our podcast, that's mueve.org, where we discuss emergency medicine topics, and take care.